of Station MD, and he serves as the medical director of an emergency department in the New York City area. He's board certified in emergency medicine and internal medicine. And Megan Kalishman, she's the chief operating officer at Station MD and has more than 20 years of healthcare administrative and technical expertise. And I am now going to just pass it off to both of you.
Thanks, Deb. Thank you very much. Megan's gonna kick it off here.
Good afternoon, everyone. How are you? Thanks for having us. We're going to just kind of talk a little bit about, the telemedicine project for the grant that we have going on right now. And then we're going to kind of talk about the rollout process, implementation process, and then kind of go into what was happening during that time and what is happening now and what the future looks like as well. So I think we were kind of somewhat fortunate with I don't know if we should say fortunate or unfortunate with the pandemic in terms of some of the challenges that it created, but it really highlighted a lot of the challenges, healthcare challenges for people with IDD, and some of the things that really show how useful telemedicine or telehealth can be. So here you can see some of the problems that individuals with IDD kind of face in terms of access to healthcare. There's a lack of access. And certainly with telehealth, it kind of gets rid of that geographic impediment. Really, the providers can be anywhere and the individuals can be anywhere as well. There's also a lot of times where there's kind of suboptimal care for individuals with special needs. What we've done in terms of Station MD and provided access for through the grant for individuals with IDD is we have board certified physicians that have specialized training as well as behavioral health training to care for individuals with IDD. We have a pretty broad range of experts across the country that have helped us develop that program. We work with Dr. Scude, who developed the Hearst risk assessment, which I know many of you are familiar with, as well as Dr. Carol Kripke out on the West Coast, which helped us with a lot of the behavioral health clues and what some of the medical underlying reasons for those behavioral health conditions are. And then in terms, we also work with a lot of organizations around the country as well, CP obviously being one of them, Anchor, AAMDD, DDNA, that provide us some valuable input in really training our doctors to give the best care to individuals with IDD. One of the other challenges, and this has been particularly a big issue during the pandemic, is access to primary care. Many of the clinics have been closed down just from a safety perspective. Many of the primary care offices have been unavailable. So Station MD is available 24 hours a day, 7 days a week, and kind of there to fill that gap when the primary care physicians are unavailable, or even if they're not able to visualize the individuals. And then, of course, there are a lot of regulatory pressures, and at Station MD, we're really in tune to those regulatory pressures and really work on making sure that our documentation is appropriate, so that when you do get, any kind of surveys or individuals from the state coming in, that you have the appropriate documentation and you're meeting all your regulatory requirements. So some of the challenges, that we see for the staff by having to go to the ERs often or to urgent cares is, I think the biggest thing is really just those unexpected shift extensions where people aren't really sure when they're gonna be getting home or off shift and when they're going to the ER, because no one really knows how long an ER visit will be. And then, of course, the other big issue is just exposure from a staff perspective to COVID and other, other diseases like flu and those types of things as well. And there's also a lot of big job satisfaction and staff turnover that we see with the support staff, and just the staff overtime issues as well that make really impact the staff morale. So if we can reduce those ER visits and urgent care visits, that really helps with all of these factors. So just kind of an update on the grant and kind of where it ended up. Right now, the grant is a 5-year grant, which I know many of the people on the call probably are aware. It provides 24/7 coverage via telehealth and a majority of the equipment costs. It includes right now 50 agencies and a little over 1,200 specific sites or homes, and it covers about 8,274 individuals. So really broad spectrum across the state. And kind of where we are now with the grant, CP was fortunate enough to be able to add on some additional agencies and additional sites. So right now where we have 48 agencies that have already been implemented on the system. Majority of those were done in March. About 1,112 specific homes and about 7,400 individuals. The remaining people will be coming on actually by the next couple of weeks. The remaining 2 agencies will be coming on, and that will fill out the rest of the groups. So kind of how did we get here? And I'll kind of turn some of this over to Dr. Kaufman, but just, you know, it was good timing in terms of the implementation, and bad timing because obviously the crisis has been pretty horrific on many fronts in terms of COVID, but it did really call for some quick adaptation, and the staff were really great in terms of being able to pick that up. The training really, we got lucky. We completed a majority of the training in February and March. We had all but 4 agencies able to do their training in person. The other 4 were very adapted very nicely to our virtual training, which we had to kind of create on the fly, but I do think it went well. And now that's all we've been doing since the pandemic is ongoing. And we did about 4 to 6 training sessions per agency. And then all of the equipment was deployed throughout the month of March, which was also obviously very challenging. We had some sites that were already in quarantine due to COVID. We had many times where the drivers were very gracious about setting up outside in pretty extreme cold weather conditions, and then just allowing the staff to come out and grab the equipment to minimize contact. But luckily we were able to get through and get it done. And I kind of talked about a couple of these things, but some of the obstacles were really, we did have a couple of inclement weather delays in some of the trainings, but we were pretty fortunate for the time frame of February and March not to have too terrible of weather conditions. And I think we really only had 1 snow day for 1 training. As I mentioned, the no visitor policy was a little bit difficult in terms of getting some of the equipment out there, but the staff at the homes was great and very gracious, and we were able to get a lot of that equipment set up outside and be able to get everybody up on board. And it was really difficult for the staff, just because some of them did have a reduction in the home staffing just because of what was going on. And of course, everyone was pretty nervous about what was happening at the time. So Dr. Kaufman, if I want to turn it over to you to talk about kind of what else was happening in March.
Sure. So, hi, everybody. So to give a picture, a broad picture of that time in March, I mean, all of you remember how terrifying it was in the Northeast. Still is terrifying to a large degree about what's happening. But this was really when COVID first hit New York City. People were very confused about what to do, how to react to that. And at the same time, it correlated in this strange way to the exact time when we had to figure out how to deploy these devices and get this program started. So people were very overwhelmed and scared. And at the same time, the need was more than ever. And I know as an ER doc, we were telling everybody, stay away from here. You were guaranteed to contract this terrible disease. So it was this really strange convergence at that time. So many clinics were shut down. So people's normal access to healthcare had disappeared. Agency programs had stopped. People were kept in homes. Access to healthcare and primary care offices were very limited or not at all. And really the non-essential, there's a typo there, but non-essential appointments were completely stopped. What happened, it was sort of this crazy time where people didn't even have PPE. The staff members I remember at this time were dealing with COVID patients, not necessarily, across the country without even, having appropriate resources. This goes for the ERs, it goes for agencies, it goes for everything. We were reusing equipment in the ER. So it was it was a crazy, very scary time. And the rates were rising very rapidly. So just to take a look, I'm going to break this down to give you some numbers here. If you look down with the red circle around, March and April, you see those cases coming up. And this is New York City as a whole. This is from the Department of Health. I'm sorry, statewide. This is statewide as a whole. You see those numbers, shooting up there in the end of March or mid-March, and then around early April, it was at its peak. But this is the time when folks in the agencies were stepping up to figure out how to implement this and receive the equipment safely. Our team, led by Megan, was figuring out how to get that equipment out there. And the CP folks and the administrators were figuring out how to support us. So it was really an amazing time where people figured out how to do this. Next slide, please. And if you look at it breakdown by, to look at the city, this is what, we were dealing with in the immediate area where our offices are and where the metropolitan area of the CP homes are. You'll see in the Bronx, it had really climbed up in mid-April. It was really a scary time. Next slide, please. And this is New York City at the Manhattan. This is Manhattan County, which is Manhattan, New York County, which is Manhattan, also climbing up, and Queens, about the same as the Bronx, shooting up in mid-April, and finally Staten Island. So it was all around the city, and somehow we were able to coordinate with the staff at the sites. At this time, I mean, if you don't remember, now we sort of are accustomed to getting groceries and getting a carton of milk and sort of being able to accept that this milk carton is okay to put in your home. But at this time, we didn't know how long the stuff lived on the surfaces of things, and there was a lot of unknown. And to do this safely and figure out how to do it, I mean, literally there were situations where we'd leave it outside, walk away from the door, someone would open the door, bring it inside, wipe it down or spray it or whatever, and take it from there. So let's move. So I just want to set the table for that was the environment that this kind of kicked off in a major way. And it required a lot of courage from the agencies and from the administrators to figure out how to do this with us. And we were very grateful. So just to review our process, look, the key is, it's not lost on us that creating more work and complexity is not something that is going to be used widely. So the key is really to make it as simple as possible. And we have kind of a hotline that activates the system, and it allows our administrators, our layer of assistants to kind of make sure that the doctor is alerted. Where is the call coming from? And can you look up any information that we have on our back end system about this individual? The next step, of course, is to speak with the doctor and start the telemedicine visit for the evaluation. The key is to make it simple. And this is not just this slide, and the next couple of slides are to show a couple of things. One is data collection is key for us to demonstrate success here and what we're doing. But it's also important for us to understand what was happening in the trends of the calls. So we are tracking our calls very closely, really by the hour, by the day of the week, so that we on our end can make sure that we have enough doctors to handle issues to the proper volume of calls. And that's titrated pretty closely. But this gives you a sense of what happened during that time. So, okay, here's where February, 59, kind of a quiet number. March, as we start to roll out, jumps to 530, April, 844. So really during April, we're seeing absolutely no primary care clinics open. Everything had just shut down. So people are desperate for things like medication refills and the most basic assessments, without which they would be having tremendous problems. And as we know, you can't, to go to the ER during that time was really, there was a lot of pushbacks suggesting that it was very dangerous, which it was. And then it's sort of, you move on to May and June, where when it really correlates to when the virus in the Northeast and the New York area kind of quieted down a little bit. And I do think that people, primary care offices and so forth were a little more accessible. But we see a tick up again over the summer. Again, I think correlating to that additional tick with COVID. And also one of the things that we have seen is, just as we've rolled out to more and more sites, we've seen people become more comfortable with using our services and comfortable with using that access to healthcare that they didn't have before. And so on the one hand, as Megan alluded to, COVID continues to be really a horrible event in our lives that we can't wait to put behind us. On the other hand, I think it highlighted gaps in care that existed for this population independent of COVID, and it accelerated the adoption by all of these agencies to say, hey, we need to use this. We're told it's easy. Let's try it out. And we know in other scenarios when there is not a scenario which forces you, sometimes people won't do something new. So at least there's a silver lining there. Next slide, please.
Yeah, and just to add to that, I mean, we were literally dropping the equipment and people were calling us an hour or two later for a visit. I mean, it was almost amazing to see. I've never, we've implemented in a lot of, agencies, and there was just some of the quickest adaptation just out of sheer need for it.
Yeah, it really was. And the willingness of staff to just go ahead and dive in was, very great to see. Many of the staff were nervous in the beginning, but very quickly became accustomed to it and comfortable. So, it showed a lot of, courage on a lot of different parts. So this breaks down the calls by the call of the week. It's a nice color pattern also. Looks like a weaving. But you can see basically there are different, we're looking at these things in different ways, by time of day and day of week. You can sort of see that if you look at as we go forward, it kind of starts to even out. And we do have heavy days and light days, and we staff accordingly. That's basically to show. And then here's the hours of the day. You see most of the time the calls are in the middle of the day, represented here in these middle areas. In the middle of the night, we tend to get less calls. Our hypothesis around that, around 3 and 4 in the morning, is there's not a lot of activity. Most people are sleeping, so they're not identifying issues that come up. Although that said, we think in those off hours, it's virtually a much higher probability that someone will get sent to the ER if there is an issue that comes up. So that coverage during those hours are really important. Next slide, please. So in general, taking a step back and looking at what COVID and the COVID crisis is doing for this population, what do we know about it? How has it impacted people with IDD? What does it mean over long term? What can telemedicine do to help? What can Station MD and there are other groups I know who are doing excellent work as well. Next slide, please. So look, this is, again, I think it's very important to go back to the science of this so that we understand and know how to address it. Our program, Station MD program, is designed to meet gaps in care during normal times. But during COVID, obviously its need is expanded, as we've talked about. But really, I think that this last year has been about COVID. So we know that it's spread by droplets. It was originally, I don't know if you remember, but originally it was thought that it was primarily via contact, people touching doorknobs and so forth, and then touching their face. And that was thought to be a major cause of spread. We now think or believe that as time has gone on, it's really a direct droplet from one person to another. So when someone speaks, there are droplets of saliva that come out. And that's why these masks on both sides of, either face is very important, because it creates a barrier for those droplets. And that's an evolved understanding. So we're not as concerned about a carton of milk as we are about talking to someone close up. And also, as we know, a major time of transmission occurs when someone, just after they contract it, but before they become symptomatic. This can be very, very dangerous. Now, I will say, just a caveat to that one piece, is that we also know from experience that in the emergency departments, when we saw a lot of caregivers getting sick, it was during times when they were intervening very closely with a very sick patient who was apparently spreading the virus and shedding the virus at a higher rate. So if somebody put someone on a ventilator and they have to get very close, and that saliva and spray got into their face, that high load of virus ended up making that person, that health caregiver, more sick. Fortunately, now we have better equipment in the ER. Getting back to our population here, the other issues that make this population particularly vulnerable is, we know there are comorbidities. People have lung conditions, immunologic compromise in this population. There are situational risks, and I'm certain this speaks very strongly to this group on this phone, which on this call, which is people living in congregate care settings, living in group homes where there's staff members that are exposed, and potentially, if not managed properly, are going to be transmitting it to other people. Individuals themselves are living in close quarters, and this is a dangerous risk. We know, especially early on, there were shortages in equipment, and there were shortages in staffing. Staff was getting sick. Staff still is getting sick. And I will mention, just as an aside to that point, we know many instances where staff really was heroic. I mean, the DSPs in this population have been heroic throughout this crisis. Staff members were literally sleeping in the agencies to make sure to continue to provide care for these folks and take care of folks. So this was really a time of heroism, and it still is. But in the beginning, there were no face masks. People didn't know what to do. It was crazy. Now that piece is at least somewhat better. And we know also that this population is at unique risk because we know they have a higher rate of going to the ER. And going to the ER requires a staff member to go as well. So this increased risks of exposure while people are in the ER. And if the individual gets hospitalized, that staff member is still turning around and coming back to the home and potentially spreading the virus. So these are all potential risks. And finally, we know there are obstacles for this population in complying with hygienic procedures and wearing masks and washing hands and so forth. There are significant obstacles to this compared to other people in the population. So combating the spread, well, we have a strategy, and those of you who have worked closely with us, we've done our best to sort of help navigate this. And there are certain elements of strategy that are critical to navigating COVID. One is cohorting, and cohorting just basically means putting people who are not infected together and people who are infected or suspected infected together. And this is a matter of space and just simple operational procedure. We don't want to mix people who are infected with people who aren't infected, or else you're going to have everybody infected. Now, I know what some agencies did was very smartly created separate homes that were sort of recovery homes. You were infected with COVID, suspected to be infected with COVID, and you were put in a separate home with staff that was geared to manage that situation and those individuals, and you kept the other ones uninfected separate. Then there are questions of how do you monitor someone who you don't know is infected or is potentially infected but is asymptomatic. How often do you take temperature? How do you monitor their symptoms? How do you monitor someone who is symptomatic? When do you send them to the ER? What kind of PPE do you need for those folks versus other people? And when do you test? These are all really difficult questions that I think all the agencies had to wrestle with. We had to wrestle with. We've come up with what we think is a very good strategy, but it certainly does require a plan. And I think that one of the bright points of this second wave is that we have plans in place. And I feel strong that we're more prepared, as concerning as it is. Next slide, please. So what can an agency do itself? So face masks should continue to be worn by staff. There should be 6 feet of distancing when that's not possible, and as much as possible, we really recommend keeping distance, individual to individual as much as possible. Hand washing, again, before and after contact with an individual, and those non-essential visitors. And this is something that we also have struggled with. We don't want to exclude family members and loved ones from visiting people, but also it's balancing the ability for someone to enjoy their family and the risk of spread. And I know that everybody has wrestled with this issue in one scenario or another. And this is even more true with this population. You know, what kind of risk are we willing to take? What is acceptable risk? What is the profile of somebody that is too high risk to subject to visitors versus others? And how do you handle that question? And then there are other issues like day programs. When do you open those? When do you have appointments? What appointments are considered non-essential? And the other concept is staff rotation. Do you want a staff working at one home one day and another home another day? Does that increase circulation, create additional unnecessary risk? And so these are all questions to ask and plan for as you're going forward through this crisis, all of these issues. They're not easy answers, but we're happy to help navigate it. And in fact, I've gotten calls from agencies out of state that have just asked us to know about the work that you guys are doing and that we're doing with you, and have asked us for opinions around these issues. And we've been happy to come up with some type of plan. The other piece of things is identifying some of the community resources. And these are things that may seem intuitive, but during the crisis, things have changed. So we don't know what urgent cares are open or closed. We don't know what clinics are open or closed. It's important for the agencies to keep track of these issues so that you know what is our point of contact. Do we have local healthcare facilities that are able to treat people with COVID-19? Where can we get tested? Identifying those kinds of access points is really important. If somebody's on a bunch of medication that requires frequent lab testing, what labs are still open? How can we get those tests done even during a pandemic? These are all things that every agency needs to evaluate to make sure they understand the situation. If they're having to drive 30 miles to get to the nearest lab, they should know that. Next slide, please. So what are the outcomes for the grant participants month by month? So on the top line here, OBS means basically we treated them where they were in the facility. We were able to handle the problem, manage the problem, prescribe or not prescribe, but give an opinion that did not require transfer to an ER. XFR, which is the second line in the outcome, means transfer. That means transfer to an urgent care or an ER. So you can see, I mean, in general, as things really kicked off in March, there was a very small number that was transferred to emergency departments, 50 versus 480 in place. And that ratio it was maintained about the same, 761 times that in April that we were able to treat in place versus transferring 83 and so forth. The general number is about 85% that we're treating without sending to an emergency department or an ER. And it's sometimes even higher, up to 88%. And I think that speaks to the different layers of care that we're able to provide with telemedicine, with the coordination of care in terms of if somebody needs blood work or an x-ray, we're able to facilitate that and help in many cases and coordinate care with the other stakeholders like primary care doctors and so forth. So I think that ratio we're pretty proud of that. And you can see this slide shows you that those percentages. So pretty consistently from 2018, 2019, and 2020, our transfer rates have been from 85 to 88%. I'm sorry, our treat in place rates have been 85 to 88%. And we consider that pretty successful. I will say just sort of our philosophy is not, we want to keep people out of the ER. That's not what we start with. We start with what does the patient need and what is the best care for this individual. And, as we've alluded to earlier in this presentation, we are convinced, I certainly believe it strongly, that the care that we are providing is not a substitute for an ER. It is better care than an ER. It is much better care. Our doctors have training specifically in this population and understand the challenges much better than if you go to an ER, a busy ER where it's crazy, and the ER doc is just going to throw a bunch of tests at this individual and figure out, how to move along to the next patient as quickly as possible, oftentimes admitting for a reason that they don't have to be admitted. And that's one of the reasons why we're so successful. So this is not a substitute. This is better. Certain percentages of patients do need to go to the ER, but we want that to be that subset of patients that really requires intervention or studies that can't be done in their homes. Next slide, please. So the other piece about telemedicine and that regarding COVID is really, it's accelerated not just adoption of our system and adoption of the agencies during the grant, but in general and overall, it has really changed a lot of the nation's view of telemedicine and accelerated the national profile of telemedicine and accelerated a lot of the regulatory changes and hurdles, bringing down those hurdles to bring about telemedicine. In New York State, I think they've done a very good job at this. And they were sort of ahead of the curve a little bit more than other states in many ways. The Parity Law refers to the billing, basically. It's a law that says that for whatever the healthcare provider would have gotten reimbursed for an in-person visit should be the same in a telemedicine visit. And that was true for Medicaid and some of the privates. CMS, the federal government, still had lagged behind on that. With New York Medicaid now allows for telehealth billing, and they have really loosened their requirements for location. There's a paradox that had existed where the patient had to be in a certain place and the doctor had to be in a certain place, even if it was telemedicine, removing a lot of the benefits of telemedicine. right? The telemedicine allows you to be anywhere, but they weren't allowing billing to occur unless these certain criteria were met, and it created a lot of obstacles. Now, location flexibility allows for clinics and OPWDD sites, which includes our population in most cases. So it really has accelerated a lot of the movement in the regulatory world, and I think that landscape that's true for most of the country, that things are changing, and certainly CMS is doing its best to move things along in a more progressive fashion in terms of telemedicine. Next slide, please. So this is sort of referring to some of the things I just mentioned. So hub and spoke is really terminology from years ago, but still was being used. And the hub refers to the patient and the location of the individual, and the spoke referred to the different caregivers or doctors. And it's required in the oldest incarnation of this said that the patient had to be basically in a medical facility and the doctor had to be in another medical facility in order for it to be reimbursed. Now, both of those areas are relaxed. The patient can be in a home setting or a group home, and the doctor can be in a home setting. He or she doesn't have to be in an office or a hospital. FQHC billing has been relaxed to a large degree. Again, the federal government has to consent to this, and they're allowing for FQHC billing to occur. Before, the doctor actually had to be on an FQHC site. Now that's no longer true, and the individual had to be at an FQHC site. That's no longer true. And we know that fortunately, interstate flexibility for billing and for licensing has been relaxed. There's been talk for many years about medical licensing being interchangeable state to state. Unlike laws, the medical treatment of people doesn't change state to state. The heart's still in one place. The lung conditions don't change if you're in Delaware or Idaho. So why should a medical license be required in a separate state? Whatever your theories about that are, there's a lot of them, but the reality is the states are trying to do their best in sort of making it easier for doctors to get licensed in different states. Next slide, please. So again, this slide actually didn't come out as well as I had envisioned. I envisioned a very demonic resurgence of COVID, which is actually happening, unfortunately. But there has been, as you all know on this call, there is unfortunately an uptick, whatever you want to call it, a second wave, a third wave, or just the first wave. But we know that the country as a whole is getting hit very hard. We know the Northeast is getting hit very hard. New York uptick we are seeing that in New York City and around the state. And I do think that we're in a much better position, as I mentioned, but we really have to be vigilant about taking care of these individuals with the same kinds of precautions that we have been using, and to be aware that this is, I think, the next couple of months, we're really going to have to be extra careful around all of these precautions. Next slide, please. So what do we think will remain? So after there's a lot of thought about, look, we're making these emergency measures. CMS and the state is making these emergency measures to get us through this crisis. Which ones will stick around? We think that most of the important ones will stick around forever. We think that the landscape of medicine and telemedicine and healthcare delivery for the general population will stick around. We think also that the model of healthcare delivery for people with IDD is going to be changed forever. We think that what the groups who are involved in this project and other projects in telemedicine around the state who have done great work, we think that model will serve as an example for change in the future, because these problems for this population are not going to go away in terms of gaps in care, in terms of enjoying the quality of life that telemedicine affords to many people in the population. People with IDD are entitled to that as well. So what is the change? The change in the hub and spoke requirement now, really, it's relaxed, as I mentioned. We think that will be permanent. The FQHC billing, again, as I mentioned, we think that's going to stick around. The one thing that we think will not persist is that licensing, interstate licensing. Although there are infrastructures in place, something called the compact, where they get to keep the money of a license, but they don't make you do all the paperwork. We do think that there will be some incarnation of that will stay. Next slide, please. So what does this mean for agencies who are pursuing telehealth? Well, there will be and will continue to be and is more opportunity for reimbursement via Medicare and Medicaid to help reduce those costs of staffing, going to the ER and so forth, and loss in bed revenue and other pain points. And then there are other potential changes adopted by the state. Other states are using the waivers to reimburse for telemedicine. Other states are using shared savings with payers in a much more robust way to reduce telemedicine, to pay for telemedicine costs. Next slide, please. So before I get to questions, I want to thank a few people. If I haven't said it before, really the individuals that we're serving who are willing to work with us and see a doctor in a different way. We're very grateful for their participation and willingness to allow us the privilege of taking care of them. The agencies themselves who have been participating in this grant, and the staff and the DSPs have been really courageous in adopting this new program and being patient with us as we rolled out and all the different types of obstacles, and showing what new programs can accomplish. Deb Williams, Mike Alvaro, Dwayne Shelkey, Susan Constantino. These folks, this wouldn't happen without them and their support and championing this project. So that's something I want to emphasize, and we're very proud of it, and we're proud to be working with everybody. We have time for some questions.
Okay. I know, Megan, you already answered some of the questions that were typed in. Somebody asked about PowerPoints, and their PowerPoint is either already on the website or will be up shortly, so people will be able to look at that. But then the other question, Megan and Matt, was about somebody asked if you have a breakout of the type of common diagnosis versus complex diagnosis when StationMD is used. And they said it goes to how many unnecessary ED visits are being eliminated. And I know, Megan, you said you do have that, but
Yeah, we do. Yeah, and I can send that along to you if you wanted to. Obviously, it's just blinded data, so I could share that with you, Deb, if you wanted to send it along as well.
okay.
The other thing I'll mention about that data and how to look at that, and the project that we're doing with the academic group, so that we are looking at that data in a very sophisticated fashion. We should have more of that data in the next few months, and that's something that I know Deb has mentioned on the calls with the grant group. But we'll have a very sophisticated study on what are avoidable ER visits, what are the diagnoses, how has this impacted cost and care, and so forth. So you can look forward to more of that for sure.
Megan, do you see that question in the chat
I
box?
do, yeah, I don't know if everyone sees, it's just the role of telehealth with monitoring of chronic disease. Consider a merger of Teladoc with Livongo.
Yeah.
So, I mean, Megan, I have an answer. So look, telemedicine and chronic disease, there is a growing industry of remote patient monitoring, which is very important and showing a lot of important work for cardiac patients, diabetes patients, monitoring blood pressures, blood sugars, and so forth. Certainly our population has its share of chronic diseases. This is and I think that is a layer on top of what we're doing. Right now we're doing essentially, episodic care and managing in the type of way that we're more accustomed to. Doing the more sophisticated device monitoring, I think, is a very interesting layer that can fit right on top of our platform as needed. And it's cool stuff. Right now, I think we are learning more and more about how to use what we've created. And I think, the folks that I mentioned at CP are constantly talking about how to do that. We at Station MD are building up a team of psychiatrists to see patients on a scheduled basis, not a emergent basis, but a scheduled basis, more traditional. But these access points to care, is really endless. I know Dwayne talks about this all the time, and he's absolutely right. This is a layer that can be built on with many different types of services. Any other questions?
I don't see any right now. Does anybody have any other questions for Matt or Megan? Oh, wait. Okay. It's just people are thanking. Oh. Megan, do you see that about?
Yeah, someone was asking about being able to, you should be able to, and you can certainly reach out to me but you should be able to print the note. They're saying the way that the staff is saying they could print the notes after the visit, they are able to print the notes first. I think that David Jordan, you can reach out to me. I'll show you. They're accessing it the same way and they're able to print the note. So I think it's just a word, terminology is a little bit kind of confusing, but they're accessing it the same way that CPU is accessing it. So I'm happy to go over that with you, but it can be printed from the system.
Okay, and I think anybody who's not in the grant, just so that you're aware that Station MD, if you have an EMR, you can give them access to that and they can do the notes for that. But then what you're saying, Megan, is that they can also print out those notes if they want to keep them on site and that sort of thing. Is that right?
Exactly, and that's what a lot of the sites are doing. They're just going in and printing them out from our system. They're always available in our system, but they just want to have the paper as well for all the staff to see if they don't have an EHR.
Okay, great. If we, so one of the questions is, if we had more money, could we expand the grant? We got a set amount of money for this grant. However, we could certainly, if we were to get, I don't know, another grant, or we could certainly expand the service, Marvin, I think is what you're asking. And yes, we were able to, originally, the plan had been with the grant to add additional sites in the out years of the grant, but because of the pandemic, we decided to rework the budget so that we could add a couple of new sites now during when actually everybody really needed it. So we did that. But part of the issue is, yes, anybody that would like to can get Station MD services, but we use the grant to pay for the equipment and for the service for the 5 years. And
we're certainly happy to work with people and, continue with the grant pricing and be as accommodating as possible. I know agencies, especially recently, a lot of agencies have reached out to us, and we've been just trying to accommodate as, people as best we can to try to keep the pricing as low as possible.
Right. And the hope is that with the pandemic, telehealth was expanded, so we were allowed to do a lot more than had been previously. And the hope is that as we go through with the grant, the data that we get that Matt was talking about with that we're doing with NYU, that will show, that we will be able to show to the state how that telehealth does in fact save money, even though everybody knows that, and provides better services, and that Therefore, these services will be paid comparably, I guess, to in-person, or if not more, so that services will actually be paid.
And then just to point out, Dwayne just chimed in too, but that you guys were successful in getting an FCC grant to expand to some additional areas in the Hudson Valley area as well, along with the FQHC in Hudson Valley. So that's
That's right.
extending to about 800 or so more individuals.
Right, so other agencies, if they get a grant to cover the service, then certainly you can work with Station MD, and, CP State will help in any way we can. Any other questions? Okay. I think that's it. So just thank you both to Matt and to Megan. Thank you for taking the time to do this. I know you both are really busy. And I do have to say that we've been doing the grant only since March. So what is that, 7 months? And we have a monthly call with all of the agencies, and I'm sure some of you are on. And we have only heard glowing reviews. Everybody is so thrilled with the service, and certainly it came at exactly the right time, so that people during this pandemic really could get the services that they needed. So thanks to both of you, and thank you, of course, for taking the time to do the session.
Thank you, Deb,
Thanks,
and thanks
everybody.
everybody.
Take care.
Thanks, everyone.
Bye-bye.
Bye.